There seems to be something, is if this distance is very long, it seems to grow longer than average.
なんか傾向があるようです。この距離が長い場合には平均的にかなり長く
Like in class 3, if the distance to the back end of the condyle to PTV is short, we grow it less.
その成長の度合いが少なくなります。
So there are 2 or 3 places in this where averages don't work. Now we're presently accumulating data and getting it analyzed. This is where we are in this research right now. But I know here in many cases if I don't make this allowance, I'm going to miss something. The unfortunate part is 1 millimeter here will mean a lot in the adjustment of the chin when you take that angle and put it out as far as the chin is. So it might be a couple millimeters in the chin. So we have to be critical. That's what I said. Here's the part of it that's critical. Now, what I did was to predict where the condyle was going to move on the Frankfurt plane. Now the angle stays the same essentially. It's 27 degrees, 28, 26, but the mean is around 27 degrees. And what happens is they do this, as I showed you. So what happens is this goes back, and as it goes back, it goes down. So I had to allow for that by taking about 1.5 millimeters in 10 years. And dropping the Bayesian-Nasion relative to the Frankfurt plane. Now, from that, I could do something else too. Here I am superimposed now on the z-axis and the condyle. Here. So that's the Frankfurt plane. What I can also do is to go up here with orbitali. See, what was that per year? I used 0.5 there too. Actually, 0.6. So we'll move that up 0.6 millimeters. So that's our prediction of where the orbit's going to be. But what we're after is the new Nasion, and we do that from Bayesian-Nasion. Now, once we got to this point, and we know now pretty well what the face is going to look like there. Now, what's the next? Without treatment, what is the angle NA likely to do? Not change. So this means then that he's going to have a straight face. PNS, posterior nasal spine. And we don't see much change in the palatal plane. We got a good bit of confidence that this is how much vertical growth is going to take place, that this is going to remain constant. That fits with what we expect. So we come up here now without treatment. And you can see I can put in the palate now. So there's his palate. The anterior nasal spine is going to be somewhere on this line. Now the question is, it's going to be here, 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 here. Now we assume that the angle Bayesian-Nasion A isn't going to change without treatment. The new NA line, in this case, would fall exactly on the facial plane. This is parallel to that. So I back this up in here, and I bring point A straight down. When I do this, then, this means that the anterior nasal spine is going to be right there, and point A is going to be right there on the line. We've completed our skeletal forecast. And we've even predicted where the occlusal plane is going to be, because the occlusal plane changes very little from the corpus axis on an angle. Now what's the next thing? Where the teeth are going to be. If the molars and the incisors are completed in their eruption, you can just about bet that the occlusion is not going to shift mesiodistal, simply due to the inclined planes of the teeth. Once they mesh in, once they grind in, once they lock in. Now, I treated this patient. I'm not sure, but I think I treated him with one arch. This boy turned out to be a New York model, so he's very, very handsome. So he's certainly not an orthopedic case. Now, our job is to arrange his teeth as nearly ideally as possible for him. So we want to take our objectives and establish what we would like him to be at the age of 19. Now we see him in the beginning here. He's got about 3 millimeters convexity. He's got a little crowding in his lower incisor area, and he's about -1 here. Roll the divider. Where should the lower incisor be? He's pretty good on. That's going to be the tip of his lower incisor at +1. In him, we would like to see about 127 interincisal angle because he's brachiofacial. So there's where the teeth should be. All right, now if I do this, there's his second molar. So he should get his third molar. He's got plenty of space for his third molar. Now we'll do this in another way. We take a perpendicular to the original corpus axis through the mesiobuccal cusp. And the lower molar erupts at 0.5 millimeters a year. So in 10 years, this would be the level of his first molar. And the tooth would come with it. So there would be the mesial surface. Now we'll see whether or not that matches up with what I predicted here based from the incisor backward. Right there it is. So both techniques. So we'll go back and superimpose on the arc now, and you see how his mandible is growing. You see how the teeth came upward and forward in his arch. We start with the palate and the intranasal spine. Directly forward, the nose grows 1 millimeter a year. So 10.8 would be 10.8 millimeters. So we take that and back right down the palatal plane, and this is the end of his nose. Now we superimpose on in, and we know that he's going to have apposition here for secondary male growth, subnasally in this direction. That's 3.5 millimeters a year. So that's where his nasolabial angle will be. All right. Now his upper lip will increase about 0.2, maybe 2 millimeters increase here. So there's his upper lip. The lower lip grows about 2.5 a year. So it will be right about there. At infradentale, 1/10 millimeter a year. Down here, 0.2 to 0.2.5. That's a good looking male profile now. Center theme is decisions. So it goes through a process. The first is to define it. Now, this pertains to every decision, a business venture, a marital problem, or an orthodontic patient. This is diagnosis. In the diagnosis, you're defining the problem. Remember the definition of diagnosis? The decision reached regarding the disease. The determination of the nature of the problem and the decision reached regarding the disease itself. And it's the first step in the decision-making process. Now, expose your feelings about it. What is your prognosis? The first thing then you do is take the models,
模型を使って
look them over carefully. We call it gut feelings.
でが
The next thing then also with the intuition is the patient's feelings. You're getting ready for a 2 to a 10-year experience with that patient. If that is a mixed dentition patient, you're looking at 10 years. Is that the kind of person you want to spend your next 10 years with? So maybe there's another step in here that should be put in. Now, look at all the options of treatment. What are all the modalities that are available to us today? Removable, fixed, labial, lingual. We're going to list them. You can use combinations of these today. So there's just not one way of doing orthodontics. So this is when we list our alternatives to the treatment or list our alternatives to any decision-making process. Now you're going to critique each one. If I do this one or that one. And right here also is the PPF. The PPF test.
PPF
What was that?
何でしたっけ PPF テス
You remember what the PPF was? What is possible? Capable of being demonstrated?
トね
The total potential? Something that's realizable? A chance within the limits of what you're doing. What is the possible? Among my options, what is
た
possible
くさんの
here?
そのオプションを
In terms of the appliance, what can I deliver? The word practical means capable of being achieved. It emphasizes prudence, efficiency, and economy. It's unspeculative and expectable. As I mentioned yesterday, this is from composites of treated patients, of groups of patients of that kind. It's the average expectancy, plus or minus just a little.
まあ
Now, what is feasible is clearly possible. Clearly possible, approvable and workable,
意味がある
the best chance of success under the given circumstance. Now, I have down here probable also. This is practical. Practical is also probable. Now, these can be put down in terms of numbers because we can get statistics. There's a probability statistically of what
ですから確率ということでありますが
You
数
can
値
do
で
with things.
表すこと
there's nothing that's absolutely certain. We have then the demonstration of treated cases individually and then the composites of treated cases that we've been going over. Because your decision now is to bring one of these techniques to bear. Now you select the appliance, and in Bioprogressive you select a sequence. That's a sequence of your action. In order to accomplish your objective, you've set your objective way up here.
やります
When you say the prognosis is, remember I said two things. One type of prognosis is a prognosis without treatment. The other is a prognosis with treatment. Now you're seeking out what is the best decision process in putting those two together. One is a prognosis of growth. But in general, we can just about assume that the mandible is going to be in its position and its form and size without treatment, just about the same as it will be with treatment in long range. That is
それは長期的に見ての話です
unless we have inhibited it. Unless we have inhibited its growth iatrogenically. So there, right there, is this critiquing of the causes of a certain appliance, one of your alternatives. Because we're going to start talking about the effects of treatment and drawing up a plan. We're going to decide to select the best alternative and sequence. Commit to it. If that's your decision, well thought out, well conceived, then go for it. Don't hesitate. Make a bold sketch, like an artist will do that has got experience, knows what he's doing. He will first make a bold sketch of what he's going to do. That's K. Bold sketch of it.
ですからざ
Commit to the
っとしたその計画を立ててその計画を実行
And
して
monitor. You're going for it. You have to monitor.
だから
For the first several years of my practice, I automatically took head films every 6 months. See a big, thick file of records in some patients, particularly if they had problems. The thicker the file, the greater the problems.
だから
We monitor and then we check back.
でモニターしてそして実際にうまくいってるかどうかを知るわけであります。
Feedback so that we can slow down or go even bolder in our plan. Our goal then is production, to get the job done. Appliance selection, we call them modalities. It's not just quite the appliance, it's what you do with it. For instance, once I get a bracket on the tooth, I can apply a heavy force or a light force. It's the same appliance, but how am I going to use it?
ですから同じアプライアンスなんだけれどもその使い方が重要なんです。
The appliances we use are edgewise, so I use an edgewise bracket.
ことになります。
But I don't use the modality that was used in the past. And when Hito first started going to Japan, he discussed it with me. He's one of the greatest guys I ever knew. Really a beautiful person. So he called me one day and he said he was going to teach everybody the basics of edgewise so that they could appreciate Bioprogressive. And I think that you really appreciate Bioprogressive if you've had experience with some of the old standard edgewise that we used to use. Two of the most excited people that I've ever had in my course were in their 70s when they took the course.
70 years of age?
We're in their 70s. Dr. Silas Klein, the Klein headgear,
サイラス・クレインという方がいましてクレインのヘッドギアって有名な人ですね。
came and took my course when he was in his 70s. He came up to me when he got finished with tears in his eyes. And he says, how much I regret that I didn't know all of this for the major part of my professional life. Now I assume there's an awful lot of change in standard edgewise that's taken place through the years. Parts of Bioprogressive, mixing it in. And gradually a lot of the younger people getting into orthodontics are using 18 slots in their brackets. It's been difficult. It's been difficult to break the habits of a lot of clinicians that were disciplined in very vigorous orthodontics. So let's look today and see what we have available to us. And I suppose that's the broadest classification. Now here, under removables,
ではこちらからやっていきます。
tissue-borne,
これは粘膜支持
and
型のもの
clasp
と、
pipes.
それからもう一つはそのクラスプで保持するタイプ。
One is resting against the tissue, the other one is clasped onto the teeth.
多分使ってるということですね。
Activators and split plates, screw plates, totally removable. These are a group of appliances. This was the father of all of them. The bionator, a guy by the name of Walters, I guess
ボル
his name
ターズ
was,
っていうんですか。
who developed the
バル
bionator,
ターズ、
Frankel,
それとフランケルもここに入ってきます。
Schwartz plates,
シュウォーツのプレートというのがあります。
Planus plane.
プレーナスプレーンというのがあります。
All of these spin-offs of the activator. I showed you patients in which, in the group of mesognathic cases, they had worked and done a good job
こういうものを使って大変有効
with
だった
cooperation.
例を。
So nobody argues that they do a lot of good. Otherwise, they wouldn't last. Now today, there's a lot of people putting extra oral traction. A lot of people are using extra oral traction in addition to the mandibular posturing. Now, we modified the crow's out appliance, and he got it from the old Jackson crib. Now, I took it and modified it. I made it lighter, better clasp, and I changed the modality of using it a little bit. Now, clasped acrylic. An acrylic with Adams clasp, arrow clasps. So you can use combinations here. I will use a lot of Ricketts. I think they're efficient, they're light, adjustable, and I think they have a distinct place in my practice, and I've had success. A lot of people call these functionals. There's a good point in it, because when they have plumpers in here, they're modifying the function of the lip. Being a chunk of acrylic, they block the tongue. So if a patient has an open bite, the tongue can't get in there as long as the appliance is in there. Functional in the sense of providing a shield and actually pulling on the periosteum. Functional in the sense of posturing the mandible forward and having the muscles that protrude the mandible activated. These are mainly the external pterygoid and the superficial fibers of the mask in class 2. In class 3, it's the posterior fibers of the temporalis and the digastrics that are activated. But the mistake we make is the assumption that a functional is only a removable. Fixed appliances also are functional. And I think that anyone that doesn't understand might be led into the fact that one's functional and one's not a functional appliance. It's not true. If you don't believe a quad helix will hold the tongue downward and backward, put one in your mouth and wear it. So let's have that right out to begin. All of these can be functional. I didn't classify them as functional and these as non-functional. Traditional, full band, bracket. If you see me use BB,
ここにB と書きます。これはバンド、ブラケットの意味であります。
that's a combination of bands and brackets. Particularly the second premolars in the lower receive an inordinate amount of stress when you chew. So they get knocked loose. I also have a lot of torque that I use on the lower molars. So I prefer to band the first molars. I honestly think if I could go through a new design on bands, maybe seeking out the materials that technology has available for us today, based on my personal experience in my career, I would never bond on another bracket. I would never bond again. I never have had the efficiency in treatment since we started bonding that I had when we were banding all the teeth. I designed all the preformed bicuspid or premolar bands. We went through 7 designs for canines before we arrived at the one we wanted. We changed the metal by making it softer. We made them thinner. We also festooned them, and we pre-contoured. So for 3 years I worked back and forth with Rocky Mountain, and everybody copied us. So beginning about 1955 to 1958, I was working with preformed bands, developing. It's interesting how 18 got adapted in the profession. If I'd have known what today I know, I would have probably made it 16 instead of 18. Because I went from 22 to 19 and then to 16 with a 15 square wire in a 16 slot. In extraction cases, I like to band also the canines so that I immediately have the availability of a lingual cleat. Okay, we have cleats on the inside of our bands that are automatically on there. If I have a severe rotated tooth, distal anywhere, I will put a band on. If I'm going to expand the lower first bicuspids with a rather vigorous pull to the buccal, it gets a band. So we'll be talking about the detail of band placement and the detail of bracket placement. I want to build in over rotation in the appliance. If it's a band or a bracket, I'm going to rotate it not from the center of the tooth, not putting it in the center of the tooth, I'm going to put it off center, so that natural in finishing it, I will over treat it. You got to think. You got to be thinking all the way through. You start finishing the day you put the appliance on. So bracketing and banding is the art that you all have to learn. And I believe in over treatment. It's something that took me a long time to learn, but that's what I learned. Now this is edgewise,
必ずオーバートリートメントします。
mostly.
これはほとんどエッジワイズ。
But it's also
フルバンド、フルブラケットというのは大体エッジワイズです。
universal.
からユニバーサルも使われることがあります。
Johnson,
からジョンソン、
twin wire.
ツインワイヤ
You go on and on and on.
Right.
Any appliance that calls for all the brackets at once.
ーなんです。
The straight wire is no different from what we used to use. The only thing I can see is that we're using a little lighter wires today, and we've got pre-programmed brackets that we're using. Dr. Andrews says that his is the only one that's pre-programmed. I can't accept that. I reject that. I think we're even beyond that now with the fourth dimension plus proversion, neutroversion, retroversion plan that we've made for the facial types and for the racial type. Everybody's attempted to get one set of brackets that would answer all patients' needs. I learned several years ago that there's not one single bracket that's going to be right for every occlusion. And what we need then is something that will more closely approximate what the individual may require.